have to say the most exciting thing about tonight is you guys. You know, I don't get to see a group of my patients or my colleagues' patients in one room at one time very often telling me stories. And a lot of the stories I heard just in milling around here were success stories. I heard about devices that are making walking easier from some of you. I heard about people who have had surgery to fix joints, making walking easier. I heard about people who've gotten on drugs that seem to be making them walk better or feel better. So the success in MS is by inches. It's a day-to-day thing, okay? And sometimes I think we're so focused on fixing the disease itself that we forget that the way to address the disease is to fix each day and each little symptom. And so symptom management in MS is absolutely crucial for quality of life, okay? And so we wanted to address ourselves this evening to a particularly troublesome symptom, which is the gait difficulties in MS and the falling that goes with it. So here's some stories. A 40-year-old woman is walking in New York City with her daughter. She's hurrying down the street to get to the theater. Suddenly, she goes hurtling to the cement, pounding her knee, stands up, bleeding down the knee, quickly bandages it up as best she can, and in her embarrassment makes up an excuse as to why she fell, and they make their way into the theater, during which time her knee throbs through the rest of the show. One scenario. Second scenario. A 55-year-old woman is going into a hotel where she is staying with her family. She goes up to the room, the suitcase in one hand, the carry bag in the other hand. She goes into the room and kicks off her shoes because she's been traveling and it's hard. And she walks across the room and she's feeling around for the lights and can't find the lights. And on her way back to look at the doorway to see if that's where the light was, she trips over the shoes she just left there, falling flat on her face, impacting her glasses, getting a big bruise around her eye, and you know, bending. Did anybody ever fall and make their glasses look like they were? Yeah. Okay, that's a second case. Third case. A 58-year-old woman is walking into the doctor's building. It's the dead of winter. She has her nice boots on, but she's in a hurry. And just as she steps up the curb, her foot doesn't quite go high enough. And she skids on the ice, plummeting back on her butt. And her only thought is, how many people saw that? And as one patient said to me once, when everybody came running when she fell down, as she lay on the ground, she looked up at them and said, "What are y'all running for? I'm already fallen." So like, what are you going to do about it now, right? So I tell you about those falls because people fall down, and in case you're thinking those 3 falls happened to 3 of my patients, they did not. All 3 of those falls happened to me. At different times, in different circumstances, for different reasons. So the first fall on the sidewalk of New York was one of 2 falls that same trip, and my college-age daughter said, "Are you catching it from your patients, Mom?" They were both on uneven ground. Anybody who's walked on the streets of New York knows the cement is not always even. And I tripped and fell and bled my way through the theater that day, right? Another one, I went into a conference, and which was that one? Was that the one in the hotel room? Anyway, the point being, it was me. The one where I fell in the hotel room, that was bad judgment. That wasn't an uneven floor. That was bad judgment. Drop your shoes, walk in the dark, walk back through a room you're not familiar with, and trip on your own shoes, okay? And then the last one was ice. There was ice right on the rim of the step. Unavoidable, right? Maybe unavoidable. So we fall for good reasons. We fall because things around us create obstacles. We fall because we don't exercise good judgment. And then we fall out of bad luck. But the problem is, people with MS fall more. They fall more frequently, sometimes more severely, and with greater injury. And when you fall and you already have MS, you're really adding insult to injury. And you don't want to do that. What I hope to give you is a lot about the causation of walking difficulties and falling in MS. I will give you a little information towards the end of my talk about some of the interventions that we have, many of which are not very successful. And that's why Alyssa's going to follow me and give a discussion of some newer interventions that might be successful. How many people with MS have walking difficulties? A lot. In a survey of 1,000 people with MS, more than 1,000 people, more than 40% of them said they had some difficulty with walking. And of course, the anticipation of walking difficulty is the primary nightmare of the new MS patient, right? They come into my office frightened, am I going to be in a wheelchair? They are thinking about their legs. But those of you who have lived with the disease for 5 years or a decade or several decades know there are many other things that you might be plagued with in MS. More than 90% of people with MS complain about fatigue. Up to 90% of people with MS have problems with their bladders. Now, this is not what I announced to the 25-year-old young woman sitting in my office who just got the diagnosis, but those are many of the things I worry about. But people are very focused on walking, and there's a good reason. We regard walking and ambulation as freedom. It's the freedom to get about, it's the freedom to manage your own affairs, it's the freedom to be in the workplace. It's all connected with walking. Now, when they did an international survey of healthcare providers caring for people with MS, they reported about 46% of their patients also had walking difficulties. So it was a pretty close match. So I would say it is true that some 40 to 50% of people with multiple sclerosis at some point are going to have walking difficulties in relationship to their disease. And of course, walking difficulty is the companion of falling. What happens when people with MS fall? Now, I always tell this scenario. When I say to my patients in the office, so how many times do you fall? That's not the right way to ask it. What I ask is, how many times a day do you fall? I don't fall every day. Oh, yeah. How many times a week do you fall? Oh, well, maybe 2 or 3. You know, it's sort of like you never ask the alcoholic how much they drink. You go, so what do you do, about a 12-pack a night? And they go, oh no, only on the weekends. I do a 6-pack a night during the week. So you always sort of get your way into getting the information. And frankly, patients don't want to tell me that they fall. The other thing they do is they sort of redefine falling. It's sort of Clinton and his scandal. You know, how do you define it? So if you don't hit the ground, that's not really falling, okay? So if you just teeter and you hit up against the wall and you somehow stabilize yourself, that's not counted as a fall, right? How many people agree with that? Oh, see? See? Most normal people consider that falling, okay? So when you do fall and you fall frequently, you have to worry about fractures. You have to worry about worse injuries than fractures. So I've had people who have injured their spinal cord falling down a set of steps, okay? You can contuse your spinal cord without breaking your neck. That's bruise. That's a very serious injury. Anyway, what happens if you fall a lot? You start to avoid falling. We're pretty smart. We don't want to fall down. So how can we avoid it? Well, if I don't get up and walk much, I'm less likely to fall, right? And that leads to further decline in walking ability because the less you do it, the less able you are to do it. Another great solution to falling is simply attach your spouse to your arm permanently for the next several decades. How many of us are doing that? I don't know how many admit to that, but many of you do it, right? I don't want a cane, Dr. Green. I don't need a walker. Okay, and then I say walk down the hall. So one arm is on the wall, and the other arm is sort of fishing for something out there, and it's because the spouse was not asked to walk down the hall with them. And so then people tell me, oh, I don't need a brace. I have this spouse, and he always gives me his arm. So what does that mean? That means you can only go where he goes. And if I had to live that life with my spouse, frankly, I would need more antidepressant than you are all taking. Now, I love him dearly, but I cannot be with him 24/7. I'm sorry, I can't. So engendering the care partner as the primary device for allowing ambulation is a very limiting way to live. That takes away your independent mobility. That leads to the next item: loss of self-esteem, loss of independence. And then the final and the worst of this is to withdraw. To withdraw from a variety of activities, whether they're family activities, community activities. I have people who love to sing in the choir. They don't sing in the choir anymore because to them it requires standing and mobility. People don't go to church because churches often are not accessible, or they don't take communion because that means you got to walk down and receive. And so there's so many reasons people start to restrict themselves. And they tell me, I don't want to use a cane or a walker, then people will know I'm disabled. Oh, they won't know that if you no longer participate, or if you sit in the back and don't bring, you know. People know that other people have walking difficulties. That's not the issue. What the issue is how can you take that walking difficulty and treat it to make yourself mobile, to make yourself independent, and to make yourself still a part of your community. So these are the challenges. Right in your own home, walking gets in the way if it doesn't work well, right? So we need to stand oftentimes to dress, although many a guy I've explained, you really can put your pants on from a seated position. I know it's not part of how you grew up. Everybody wants to be standing there yanking on the pants, but there are adaptations that allow you to work around your gait and walking difficulties. But dressing, bathing, grooming of any kind, standing and looking in the mirror, all of those things require activity of your legs. Food preparation and cooking, which is central to a lot of people's lives because they're the primary homemaker, that requires oftentimes standing to be done efficiently, or moving about the kitchen. Moving about your own home is part of being free and independent and self-sufficient. All of those things require walking. Managing other things in the home, doing the laundry. So I have people whose laundry facility is on another floor of the house or requires moving from room to room. Laundry chutes are sometimes a thing of the past, but there are ways to work around. Cleaning and cooking, as I said, or managing childcare. All of these things rely on legs. And I've had many young moms who have ambulatory difficulty. They begin to realize the stroller is their great friend. They use the stroller to move the baby and to move themselves. So there are other adaptations that can be done. Walking difficulty creates great worry for people in the workplace. They don't know how they're going to move about the plant or the office. They can't get to the bathroom because it's on the other side of the building. Or they ask for handicap parking, but of course even the handicap parking is a little too far because all the CEO and all the executives get the upfront spots, right? I've written letters about that, okay? So, and people are reluctant to put themselves in a position of others knowing that they have these difficulties because they're concerned as soon as you say you fall down easily or you can't walk well, then you're putting the boss at risk. Then there's a liability issue and they might want you out of the workplace. So people tend to hide their ambulatory difficulties in the workplace. And that's another big challenge for people with walking problems in MS. And then this is the part that I just hate. When I hear people tell me I don't go to my grandkids' games because I can walk around the house, but I sure can't walk across the ball field, so I'm not going to go. So walking restricts attendance at sports events, going with friends and family into restaurants, going to the park or the zoo or whatever activity that the group is taking. And I think it begins to impact on emotional health, because once you don't have access to your community, to your family, to your friends, because of your legs, you've let your legs get in the way of that, then you're really restricting yourself in a lifestyle way. And that's what we call sort of the tertiary psychosocial complication of an MS symptom. You know, the MS symptom is walking difficulty. The secondary effect of that is falls or poor endurance, but the tertiary effect is isolation and being left out. And that's what we want to combat. If we can't cure your walking difficulty, we're going to certainly try to make it better. We're going to try to get you to be smarter about it and figure out the means by which you can remain a part of your community, your friends, your family. So what is it that MS does to walking? Why is there such a huge impact of multiple sclerosis on the ability to walk? So I remind you that MS is a central nervous system disease. Many of you go to my and other of the neurologists, the MS specialty talks all the time. And we talk about the fact that this is a CNS disease, central nervous system. Why? Because there's demyelination, stripping off of the myelin, and axonal degeneration, injury to the nerve cell itself, the nerve fiber, as a result of attack on those components. And those are the components of the central nervous system. Why? Because it's only the CNS myelin that's a target, and the CNS axon. The CNS is brain, spinal cord, optic nerves, cerebellum, which is a big lobe at the back of the brain, and the brainstem that connects the brain to the spinal cord. All of those parts of the nervous system receive their myelin from a particular cell called the oligodendrocyte. That is the central nervous system myelin-making cell, and it is what's under attack in the autoimmune disease we know as MS. Not the peripheral nervous system, not the nerves out in your arms and legs, not the nerves going to your internal organs. So the nerves to your heart and your lungs, the nerves that supply your bowel, they are not under attack. That's the peripheral nervous system. Gait disorders in MS therefore originate in different parts of these central nervous system pathways. And it isn't just one location that causes walking problems. It's multiple different locations. Each one of the pathways that I'm going to talk about with you has a different effect on the process that we know as walking. What is the anatomy? What is the central nervous system job for walking, and what's the peripheral nervous system? As with all voluntary activities, and walking is a voluntary activity. It's not like your heartbeat. Your heart beats whether you think about it or not, right? You breathe whether you think about it or not. Lots of things are involuntary and controlled by the nervous system. But walking is a voluntary process. We want to walk, we get up, we move. It starts in the frontal lobe of the brain, the left side of the brain for the right side of the body, and vice versa, right? So initiation of walking begins with a thought in the frontal lobe of the brain, and that is where there are some what we call motor association areas that actually plan the complex process of walking. Probably the most complex thing we do with our hand is writing. But one of the most complex things we do with our legs is actually walking, and we don't have to think about it, right? We don't have to call into consciousness each piece of it when it's working properly. But when it's not working, we have to begin to think about each piece of it, all right? So then the motor command from the frontal lobe goes through the motor homunculus. The motor homunculus is just a strip of the frontal lobe where each part of the anatomy is represented, and the beginning of the motor fibers are there. So you've got a place for the legs right towards the center. Right next to it is the trunk. Right next to that is the arm and the face. Okay, so in order to work to walk rather, it is the motor homunculus that's in the center here of the frontal lobe that has to get its signal from the motor association areas where the walking is planned. And that's just step one. That's step one. It then goes down and out to the limbs via a whole network through the brainstem, through the spinal cord, and then out to the nerves of the arms and legs. That last step is the PNS. These processes, that's central nervous system. Motor commands going through the whole system, that's central nervous system. But the last leg of it is the peripheral nervous system, out in the arms and legs. And you can imagine there are other diseases, peripheral neuropathy, polio, many other diseases that affect the peripheral nervous system, but MS is not one of them. So here's a little bit of a diagram, okay, on an MRI. This is the brain, the cortex. The frontal lobe is here, right up front. Right behind it, and we're going to talk about this area in a moment, is the parietal lobe. The motor strip goes across here, and that's where these signals originate. They then make their way down into this structure, which is the brain stem. It's a stalk attaching the brain to lower areas, and here's the spinal cord. Once the nerves leave the spinal cord, the next set of nerves, that's part of the peripheral nervous system. But all of what you see here is the central nervous system. And here's a more detailed view over here. This gray structure right at the center is your spinal cord. And this is a normal MRI you're looking at. There are no MS spots on here. I just show it to you to give you an idea of the anatomy. Back here is another lobe of the brain called the cerebellum. And we're going to talk about the cerebellum's influence on walking. So the frontal lobe is the motor influence. The parietal lobe is where the sensory system is housed. We're going to talk about that. The cerebellum is another important input. And then everything has to traverse that brainstem on down into the spinal cord to get to the arms and legs. And specifically, we're focused on the legs here with walking. What about sensory input? The sensory input has to be constantly feeding back to the brain to tell your brain if you're moving your legs right. So the sensation in your legs tells the brain where your legs are in space, how fast the limbs are moving, in what direction they're moving, and what they're moving on. We rely on sensation to tell us what the slope of the floor is. We rely on sensation to tell us if we're on uneven ground. All of that is sensory information. And very quickly, as you're walking, that information is feeding back to the brain and giving it very important information to readjust the motion of your feet, right? So obviously, if you can't feel your feet on the floor, you're not going to walk very well, right? So these are crucial integrated functions, sensation and motor. Where's the sensation come from? Well, you got sensory receptors, they're called, in the skin. And you have some under the skin, in the structures just under the skin, in the muscles and the tendons. So as you're moving, as you're walking, your skin is touching a surface, but your muscles and your tendons are moving and feeding back information from sensors in those locations. Then the sensation goes up that spinal cord I just showed you. The motor tracks go down. The direction of the sensation information is back up. And that sensory information is organized in different tracks. There's a sensory tract that feels temperature and sends temperature signals. That's why when you step on something hot or you touch something hot, you move off. There are sensory tracts that tell position. They're actually tracts whose duty it is to indicate what the position of the limb is, and other forms of sensation. Each of them have their own pathway. And frankly, MS, when it's in the spinal cord, can pick one or another pathway and mess with it, right? So all of that is central nervous system information once it's in the cord and up into the brain. In the brainstem, they're actually, they're called nuclei, which are groups of neurons that are receiving the sensory information and sending it in all different directions. And then up in the brain itself, there's an area called the thalamus. It's another sensory relay station. And interestingly, one of the areas of atrophy in progressive MS is in the thalamus. So the thalamus is an important sensor. And then finally, all of that goes up to the cortex, the brain, where we have organizational places for sensation. And that is the final destination of the sensory information that then has to feed back to the motor system so you can walk. So where is that? That's the parietal lobe that I mentioned. It's right next to that motor strip called the motor homunculus. And sensory systems are crucial to integrating sensory information. So for example, I put stereognosis here, and that's just an example of a higher sensory thing. When you pick up an object, if you don't look at it, you can identify it if your sensory system in your hand is working right. What do I mean? You can tell if it's hard, if it's cold, if it's irregular in shape. You can tell all of that, and then you know it's your car keys that you've been looking for the last hour, right? Same thing with the leg. As you step, you integrate all of that information that's coming from what your leg is feeling. You can feel what the ground feels like. Is it soggy? Am I falling into it? Am I walking in mud? Is it pulling on my shoe? Is there tape on the bottom of my shoe? All of that information goes up the sensory system. What else goes up the sensory system at the same time? The pain in your knee from the joint that needs replacing, right? So you are integrating all of that information when you are moving forward and walking. It's a complicated process, guys. It is not simple. Isn't it miraculous that the brain can do all of that? And that you watch babies learn to walk. Is there nothing more entertaining than that? Right? And so neurologists, of course, we're a little different. So we watch a baby walk and we go, you need a little more myelin, honey. And you know, this is my kids are like, mother, you know, they're staggering. And I go, your cerebellum is not working yet. So babies, literally babies are myelinating and they keep falling down. But of course they only fall 10 inches, 3 inches. It doesn't matter. They fall all day long and we think it's a hoot. And then eventually they stop falling. Why? Because all this stuff gets myelinated and this integrative process becomes honed. And you think about it, a baby goes from not walking, by the time they're 2, they're running across the room. And this is a phenomenally complex process that has already matured just in the first couple of years of life. So if you're a grandparent, you enjoy this, you know. You got to get your kick somewhere, right? Okay. I mentioned the cerebellum several times, that thing at the back of the brain that I showed you before. It is an important brain center for balance. It fine-tunes limb movements. When your cerebellum doesn't work, your hand, instead of going straight to a target, does this, okay? When the midline cerebellum doesn't work, you begin to have this or this. You begin to have tremor, or what's called titubation, truncal movement. So the cerebellum is a modifier of walking. Another modifier, which is not part of the central nervous system, is the inner ear, okay? And 99% of the time, when you have spinning vertigo and it hits you suddenly, it's from your inner ear, not from your MS, because clogged sinuses or viruses or whatever gets to the inner ear. Now, the ear, nose, and throat doctor will always blame it on your MS, and the reason for that is you can't see inner ear disease. You can look in the ear, but you can't really see it. So he'd rather blame it on your MS. But the truth is, we all get inner ear problems. But the inner ear information feeds into the brainstem, and it's important information telling the brain about the direction in which your head and body are moving, the speed at which you're moving, the torque, the sort of the angle of your motion. That's important information. So if you put inner ear problems on top of MS, you got a big problem sometimes. And then the final important input for your walking is the one that I didn't have when I was walking across the dark hotel room and tripping over my own shoes, and that is vision. So we all need our eyes and our optical pathway to continuously notify ourselves about the environment that we're moving in. So if you don't see the obstacle on the floor, and you happen to have feet that don't feel things quite right, you're a lot more likely to fall down, right? So you can begin to see how small impairments in multiple areas of the system can make for disaster as far as walking and falling. But even just one misinput, you know, normal people get an inner ear infection and they're staggering all over the place, right? Or take my mom, 90 years old, God bless her. She has peripheral neuropathy. She can't feel the floor, cannot feel the floor. She's got macular degeneration. She can't see. So her propensity for tripping and falling is unbelievably high. And she doesn't have MS. So it's really many different diseases can cause these kinds of input problems. So how does MS, what's the outcome of the MS deficits on the MS gait? So here I want to address myself to the different kinds of walking abnormalities people have, and every patient is unique, but there are categories of walking difficulties in multiple sclerosis. So spinal cord disease causes weakness. It may be a monoparesis, just one bum leg, or it may be both legs get affected, depending on how much disease you have in your cord and at which locations. So it can be a monoparesis or a paraparesis, is what we say when it's both legs. And so what's the gait look like? People begin to drag a leg, right? Or they circumduct, they swing it. Because if you can't pick up the foot, you just bring it around in a circle. That's called circumduction. The other thing is when the leg gets weak, people hyperextend at the knee. They snap their knee backward. Why do they do that? It's involuntary because what the leg is doing, what the brain is doing is saying, if you let it be bent, it's going to collapse because your leg's not strong enough. So with each step, if you snap it backward, you lock it. And so there are people whose biggest problem with gait is this tendency to hyperextend the knee. And what does that lead to? A lot of knee pain. A lot of knee pain and knee disease. And then, of course, all of this leads to falls. Now, what about sensation? When you don't have sensory input properly, you begin to get what's called a sensory ataxia, where you just can't feel the floor, so you tend to widen your base and you stagger as you move. That's called a sensory ataxia. It leads to staggering, weaving, falls. There's another motor phenomenon that only some people with MS have, many people do not, and it's called spasticity or hypertonicity, where the muscles become tightened by virtue of the fact that signals from the brain are not getting down to the spinal cord, and so you have a disinhibited reflex arc, is what it's called, where your reflexia becomes hyperactive in the leg, and that causes your leg to spasm, or your foot to bounce like this, which is called clonus, or for the leg to just be stiff. And that kind of thing leads to abnormal walking as well. One of the things people with spasticity do, besides being stiff and robotic in their walking, is sometimes they scissor, where one foot goes in front of the other inappropriately, and then they're tripping over their own feet. Or the foot's driven downward in what we call a foot drop. Or the foot's driven inward, and it's just painful, okay? So there are many different ways in which effects on the spinal cord affect ambulation, walking. What about that cerebellum that I keep going back to? What happens when you have faulty inputs from the cerebellum? And the cerebellum brings its information into the brainstem, then goes down into the spinal cord or up into the brain itself. So it's connected in multiple ways to the rest of the system. But I said to you before, you get something called titubation, which is sort of movement of the trunk involuntarily because you're not smoothing out movement properly, and that throws people off balance. In the limbs, you can get just shakiness, and you can have that in the hands if your hands are affected, but you can also have that kind of shakiness in the leg, and that's likely to lead to falls. So it's sort of a drunken gait with a tendency to weave from side to side that we see in patients with primarily cerebellar difficulty. What about in the brainstem itself? The brainstem was just that stalk between the brain and the spinal cord. Well, everything has to go through there. So you've got to get motor information down through there, sensory information back up through there. The inner ear information feeds directly into the lowest part of the brainstem called the medulla, where there are groups of neurons that receive that information. And if you have MS in the brainstem, that in itself can also cause vertigo and dizziness and gait imbalance. And then MS, of course, has this wonderful additional brainstem effect on eye movements. So even if you can see just fine, you don't have optic neuritis, your eyes may not move in sync. Then you have double vision. Or you can get something called oscillopsia, which is where everything looks like it's wiggling. And that's because the eyes themselves are moving. It's sort of the same thing like tremor in the limbs. It's tremor in the eyes. We call that nystagmus. And if you have that kind of visual distortion, it too will impact on how you see and how you move. And finally, back to vision itself, MS involves itself with the optic nerves. It can cause acute, sudden visual loss, and there's nothing worse than all of a sudden being monocular in your vision. You lose your depth perception. But even slowly over the course of the disease, sometimes people get this progressive, slow visual loss that they don't even know quite is happening. And pretty soon, it's that they don't see edges well or differences in color. And so those kinds of visual distortions can lead to what happened to me in the hotel room. You need to see where the floor drops off. You need to see where the walkway becomes a step. And so if you have visual impairment, that too is going to lead to much more likely gait difficulties and particularly falls. Okay, and MS people who've had optic neuritis complain to me all the time. When I go out into bright light in the sun, it's like everything's whited out. And by the same token, the same people may say to me, when the light's dim, I can barely see, so I can't drive anymore. You know, those kinds of things. How about MS in the brain itself? You know, my patients worry about cognition. Most people with MS think actually very well. Okay, but about 50% will have some subtle changes. Those people do not have brain effects on walking. But there is a subset of people, a small number of people with MS, whose biggest problem is that they are disrupted cognitively and the planning areas for walking don't work well. And what that results in is something called gait apraxia. Praxis is the ability to perform a coordinated motor task that you've always known how to perform. And so if you have apraxia, then what it's saying is you can't perform that coordinated motor task that you should normally be able to perform, even though you don't have paralysis or you don't have sensory loss. You just can't organize it. And people with gait apraxia begin to walk funny. It's like they can't get the feet to move forward. We call it cementing. They can't organize walking function. And that can be just as bad as being weak. It's just different. It's a different form of gait disorder in MS. Okay, one other thing about cognition is my second paragraph here, is why do people fall? They fall because, like me, in my falls, they use poor judgment. They don't plan for the piece of ice and they don't look for it, or they don't wear the proper shoes, or they decide they really can lean way over with the cane over there to pick up that little scrap of paper on the floor because they don't like the mess in their house. So there are many judgment calls that, if you don't do things properly, can lead to falls, right? And that's cognitive, but that's normal. We're normal. We make poor decisions. It's the people who keep making the wrong decision over and over again that worry me, okay? You need to learn from your errors. You need to accommodate the gait and walking difficulty so you don't crash to the floor. There is some differences between MS and its walking difficulty and other diseases. If you have a spinal cord injury and you end up with a paralyzed leg, that leg is the same no matter what the time of day is or what you've been doing. But in MS, we have this unique phenomenon of walking endurance, where there is a sense that the first 100 steps are okay, the next 100 steps are slower, and then finally you can't walk any further. That's unique to MS because what happens in MS is conduction difficulty, where you can get the signal normally down some nerve cells, slowly down other nerve cells, and not at all down some nerve cells that are either dead or too demyelinated to function. And the result of that is what we call motor fatigue. So your walking changes depending on the time of day, how far you've been walking, how long you've been standing, and then it also may depend on other factors around you. So the fact that it may be too warm in the room can impact on your gait. There are many different things that affect the endurance of walking in MS, and that's unique. The other thing that's sort of unique to MS is those superimposed movements. I talked about a foot that's flopping or a leg that goes into a spasm, which might suddenly throw you off balance. Sudden pains can also make a limb collapse. You know, when you lift a box that's too heavy for you, your body's smart. If you start to pull so hard that it's going to detach your biceps, you'll let go. You will let go. That's a protective reflex. People with MS have similar protective reflexes. If they have sudden pain in a limb, that limb's going to collapse and they're going to begin to go down or stop walking at any rate. So all of these can be unanticipated and can really negatively impair your ability to get from point A to point B. Then there are other things we don't like to talk about, which are what we call comorbidities that affect MS walking. So health issues, obesity, which is a chronic problem in a lot of MS patients, arthritis, which happens to many of us as we age and which can impact on the MS, smoking, which we now know to be a factor that causes worsened MS, but it also causes lung impairment, and it gets harder to walk if you certainly if you can't breathe well. So respiratory disease, cardiovascular disease, all of these things have impact on walking. And I've had patients with MS who have a sudden decline in walking, and I discover they're anemic, or I discover they're hypothyroid, and that's why they're not walking as well. So we can't forget that there are other forms of health that need to be addressed in order to maximize walking ability and prevent falls. And then there are all these medications your doctors very happily and willingly and not always so smartly give you. So we give you medication for spasticity, but some of those medicines can cause weakness. We give you pain medicine, but that can make you a little airheady and not pay attention to what you're doing, right? And even the disease-modifying drugs, the drugs for your disease to prevent worsening, can have side effects that impact on walking. If they make you lightheaded, or they make you nauseated, or something negative, that may impact on your function. And then there's the personal differences. So tonight I told you, I heard from a bunch of heroes in this room who finally took the step to get a device, or to go to therapy, or to replace a joint to make it better. And I have to tell you, personal choices like that, being committed to exercising, or being willing to adopt a new lifestyle change, or willing to acknowledge the defect and look for an intervention, is key to walking better in MS. It absolutely is. And I don't want that to be forgotten in all of this. So just a few words on how we measure this. It's not just that the patient tells me they can't walk well. There are things we can definitively measure. We do EDSS scoring, which is scoring disability, and there are different points we give to people at different levels of walking ability. We use something called the 25-foot timed walk. Corey does it all the time for people who want to go on Ampura. You click the timer and you say walk to the other tape measure. And that distance and the time it takes is a good measure for following somebody's walking ability in MS. And there are other forms of timed walking, the 500-meter walk. And then there's a scale that's used in certain studies called the MS walking scale, in which the patient themselves describes the different aspects of their walking that may or may not be good. All of those are measures that can be used by the clinician or can be used in clinical trials. But one of the things I always ask patients when they will come in the door, walk in the door hopefully, is your walking as good as it was 6 months ago? Is it different than it was a year ago? Because sometimes walking changes are subtle. And once we know it's changing, we want to address the factors that are contributing to that change. Who does this? MS neurologists, physiatrists, rehab doctors are very helpful in making these assessments. MS specialty nurses in our MS center who talk to you on the phone day in and day out and ask the right questions so that we can recommend either the medication or the non-medication intervention that's going to make it better. And then tremendously we are relying on our rehab partners, the physical and occupational therapists. And you know, everybody knows physical therapists are for the legs and occupational therapists are for the hands. But a lot of my patients walk with their hands as well as their legs. They're dependent on a device or in shifting their weight to a device. And it's very important that we engage all kinds of therapy to maximize people's ability to move. They can implement exercise programs, but they also make the recommendations of ways in which to walk better and to fall less. Always my patients want a drug. Everybody comes in, I want to lose weight. Isn't there a medication that will fix it for me, Dr. Green? And I go, look at me. If I had such a medicine, would I look like this? And I say that over and over again, but nobody gets it. But it's true. It's true. There isn't a medication fix for everything. But what do? Patients tell me when I'm on the steroids, I can walk great. The reason is that steroids enhance conduction down nerves while you're taking them. It is not a long-term fix. You do not want to stay on steroids chronically because they don't fix the disease and they cause a bevy of bad side effects. Ampera, that was supposed to be the miracle. It's the walking drug. But Ampera, which is 4-aminopyridine dalfampridine, which enhances demyelinated nerve conduction, doesn't work for everybody. It works for some people. It does make it easier for some people to walk. Baclofen, we talk all the time about getting rid of spasticity, but baclofen's a mixed blessing. You take away the stiffness and sometimes then you don't have a leg to stand on. So you sometimes need that stick in the leg to stand. Tizanidine, it's a different mixed blessing. That's Xanaflex. A lot of people love Xanaflex. It loosens up the muscles, but a lot of people have too much sedation with Xanaflex or hallucinations at night or nightmares with Xanaflex. So again, a mixed blessing. People ask me, well, my legs are tired. Give me a medicine for fatigue. But our fatigue medicines, the ones that we use for the lassitude, the general fatigue in MS, don't really work for the neuronal fatigue that makes the legs weak. What about Botox? Can we use Botox for walking? And it turns out that Botox has very specific uses in certain gait problems. So in somebody who scissors because their legs are being pulled together with what's called adductor spasticity, you can loosen that up with Botox. Sometimes people who a foot is turning in severely and they can't wear a brace properly, you can loosen up the muscles that are doing that and then the brace can be comfortably worn. So it isn't a fix, and no, I don't use leftovers for your wrinkles or my own, but Botox is a useful intervention in a limited way. So, I presented the problems. I presented, I hope, an accurate or fairly accurate anatomy for you to understand the varying problems and where they're coming from. I did not go into great detail on rehab because, Alyssa, this is the come on for your next talk. You're going to hear a lot about that. But as time goes on, my hope is that we will have better and better interventions for ambulation. They're working on new gait devices. They're working on robotic things that would help get signals from the brain down to the legs, bypassing the defect in the spinal cord. I mean, there's some amazing things that are going on in the research world, and I'll just name one, and maybe Alyssa knows about this, but I was at the meeting in Boston for the European and American MS community, if you will. Doctors, investigators, researchers, everybody who manages MS. And I saw in one booth, the guy had a new walker. This walker had a seat in it, but it was a walker. And so what you do, you got a lever, you lower the seat, you put your legs over it, and then you do the lever, and the seat comes up underneath you, and then you walk with the walker. But you got this support device inside the walker. It was quite unique. You know, it costs too much money, and I don't know how many people it'll work for, but the point is people are innovating, people are directing themselves to this difficulty of walking in MS.
Okay, Dr. Green, is the thalamus visible from an MRI?
Yes, the thalamus is right in here, right in this area, right in there, okay? So you've got your ventricle above it, and the thalamus is, it would be easier to see it on a different view, like an axial section, which I don't have on this, but that's where the thalamus lies, okay?
This is kind of a specific question. One of the members of our audience said that their thyroid TSH was normal, but could there be something going on in the thalamus that could be altering this or that you didn't know was going on?
Out of my area of expertise, the thalamus, though, does not have anything directly to do with the thyroid. The thyroid gland is another location, and the thyroid gland is in your neck, actually, but TSH is a stimulating hormone that's produced deep in the brain in the hypothalamus area, and so maybe that's what they're referring to, and the TSH then stimulates your thyroid gland. But I didn't mean to imply that disease deep in the brain in the thalamus has to do with these other disorders. These health disorders like low thyroid or anemia or arthritis are separate from MS, but compound the problems of walking in MS.
Okay, thank you. What about Nordic poles?
Nordic poles, well, there's so many good ideas. Alyssa, are Nordic poles a good idea?
Nordic poles for the right people, yes.
Are you going to talk about them?
I can.
Good. So we're going to let her answer, but there are many times that I've recommended to patients to use walking sticks. And there are a lot of patients who find that if they do use 2 walking sticks or 2, basically these are ski poles, that allows them to take a walk in the park more safely than if they were not to use them.
What causes the fatigue?
The fatigue in the limbs in MS is caused by slowing of conduction. So once you strip off myelin, then the nerve fiber that is still alive can conduct, but it conducts much more slowly. And if you strip off enough of the myelin through the whole course of the nerve, you may actually get failure of conduction. And so when a marathon runner runs, he gets to mile 22 and he feels like his legs are not going to make it anymore. That's neuronal fatigue. He doesn't have enough safety backup. For the MS patient, that same fatigue is we don't have enough neurons doing the job anymore. And so after you use up or fatigue some of them, you don't have enough backup. And that could be after 100 feet or 100 yards or a city block, depending on your MS.
What about medical marijuana?
What about it? Let's have a party. The little data that we have on marijuana was actually put out in a paper by the American Academy of Neurology not very long ago. And that was marijuana's usage, medical marijuana, across a host of neurologic diseases. But in MS, they said that there have been some studies that suggest that it helps with pain and some spasticity. And then there are some studies that actually suggested that it had some positive effects on bladder dysfunction. That said, it was low-level stuff. It was not considered high-level evidence. And marijuana has been tested in a whole variety of different fashions. There's a spray form, an inhalant form of cannabinoid that is used, which doesn't have, you know, all the components that the smoked marijuana does. There's been a pill on the market here for decades called Marinol. Early on, I tried it in patients who were sure marijuana helped them, and it never helped them. And so finally, the problem is that if you do directly smoked marijuana, there's very good evidence that daily use of cannabis in that fashion causes cognitive worsening in everybody, which is compounded in patients with MS. So it's not our first line of attack. More data may come as it becomes more readily available for people to do research with.
This one just says physiatrists, orthotists.
Orthotists? Like what are those? Okay, so rehab doctors, specialists are called physiatrists, or they do physiatric medicine, which is medicine that directs itself into rehabilitation of all kinds of neurologic disease, whether it's stroke, MS, Parkinson's disease, and so forth. Orthotists are the people who make devices, who make braces, who help fashion different devices for assistance in walking. Alyssa can define it better for you. That's it?
That's it.
Everything else was perfectly understood.
Join me.
Anyway,
Thank you, Dr. Green.
thank you for your attention.